good evening, everyone, and welcome to Military Medicine Part 1. Hello, my name's Anthony Bailey. I'm a psychiatry trainee in Greater Manchester. I'm a proud ambassador of the charity UOK-Doc. Thank you to everyone who's attending this evening, and a big thanks to Professor Neil Greenberg for generously donating his time to talk to us this evening. It's a real privilege to have him here. He's quite a big expert in the field. A big thank you to our partners for this webinar series. So that's First Responders First. And there's a few other partners I'll go on to speak about. We've got two housekeeping points for this evening. So if you fill out the survey that pops up at the end of the webinar, that'll help us continue with our research and kind of tailoring webinars for you, but also it will help you as you'll get your CPD certificate. And please do comment and ask questions on Zoom so that we can put those questions to Professor Greenberg and to Chris. And finally, a huge thank you to both our partners, so First Responders First and our sponsor, Draeger. And without them, this wouldn't be possible as they have provided some funding towards the webinars. Your host for this evening is Chris Cherry, who's a psychotherapist and is also a trustee of UOK-Doc. And I will now pass you over to him, and I'll see you later for the question and answers. Bye.
Thank you, Anthony. Neil, welcome. Thank you so much for being able to come and join us for the second webinar in the Microsteps series. What would be really good to start with is just your background. I mean, you've done such extensive work, and where you've got to now. Just place it in context. What's been your clinical journey?
Yeah, well, it's always good to start with something that I can know the answer to. So that's one I can. So basically, I'm a psychiatrist too. I served in the British military in the Royal Navy for 23 years. And so I joined the Navy whilst I was still at medical school. And then when I finished my medical training and did my house jobs, I went and spent 3 years doing general duties jobs. So on ships and submarines and with the Royal Marine Commandos, doing eating lots of mud. And doing sort of general doctoring things. And then I specialised in psychiatry when I did my specialist training. I did that at a few different places around the country. And then when I finished, I ended up being both an academic psychiatrist, but also being a sort of an occupational psychiatrist. So military psychiatry is a sort of funny branch of psychiatry in the sense that we're trying to get people better, absolutely. But we're also trying to get them occupationally fit so they can go back and do those challenging jobs. And then once I left about 7 years ago, I've carried on my research interest in the military, but also a lot to do with other organisations that predictably put people in harm's way. So our team at King's College London, we have a health protection research unit. So actually for the past 6 years, we've been doing sort of work on outbreaks, obviously are much smaller outbreaks than these, things like SARS and MERS and Ebola and the like, and also looking at the post impacts of things like terrorism and major disasters. On the mental health of people who work in organisations. So that's kind of my interest is how do you keep organisations functional, not just to protect people's mental health, which is important, but also in terms of their occupational function. And I chair the Royal College of Psychiatrists Occupational Psychiatry Special Interest Group because I'm really interested in that interface between mental health and people's ability to carry on delivering hopefully a high quality work output.
I mean, one of the things we particularly wanted to focus on tonight was Ptsd, and particularly because of your experience within the military, there would have been a lot of experience, knowledge, insight that you would have gained about it. Just could we start by what is Ptsd? Let's just start with the basics.
So just before I jump into that, I will answer that question. It's just worth saying that usually if you mention military mental health, then everyone thinks that the next word needs to be PTSD or the next words need to be PTSD. Yes. And it's just really important to put it into context that although PTSD is a really important disorder for people in the military and other professions, it's not the most common problem. So for instance, I was the visiting psychiatrist for Afghanistan in 2007 and 2008. So I'd routinely go out there to support the mental health efforts out there. And you'd see people who have been through really tough times. But actually, the biggest problems mental health wise were my wife doesn't love me or my boss isn't treating me fairly. Yeah. So that stuff. So having said that, PTSD is a mental health disorder. It's one of the rare mental health disorders that is known to have a specific cause, which is being exposed to death, threatened death, serious injury, or sexual violence. And as a result of that, people go on to develop 4 different groups of symptoms. So they can develop re-experiencing or intrusion symptoms, such as nightmares and flashbacks, so it's happening again, or being triggered, or for having intrusive thoughts about events. It comes with avoidance, so you don't want to speak about it, you don't want to go near anything that reminds you of it. It changes the way you think and your emotions, so you start to have distorted perception. The world is no longer safe, I can't help anybody, I'm bad, I'm evil, everyone else is to blame, and you feel numb. And then lastly, it has arousal symptoms, so you're jumpy, you feel irritable, you can't sleep well, and you're always looking out for threats. And you put all those symptoms together, you wait for at least a month after the traumatic event, and it has to impair your function. So it's really important to note that after a single traumatic event, most people have some of those symptoms, and those symptoms normally dissipate by themselves over 4, 6, 8, 12 weeks. And they don't need anyone like us involved, no mental health professionals. They need people to spend some time with their loved ones, go for a run, have a glass of wine, let some time pass, reflect on what's happened. And most people recover from those symptoms without the need for any professional intervention, and they don't have PTSD. PTSD affects a minority of people exposed to trauma. So our work in the military, for instance, shows that the highest rates of PTSD we find are in people whose last deployment was in a combat role, so combat veterans who have now left the forces. And our work from the King Centre for Military Health Research shows that about 17% of people in that group are likely to have PTSD. And that compares to the general UK population rate of about 4.5%, because road traffic accidents, disasters, and other such things happen to all of us. But most people in the military don't have PTSD.
Is there a percentage, the data for within the medical profession, PTSD?
So that's a really interesting question. And the short answer is there's no good data. And it varies immensely depending on the context in which someone works. So for instance, if you happen to work in critical care or an accident emergency, or you're a paramedic, you're routinely exposed to trauma. And actually some of those people actually are perfectly okay, it's what they do. But then really occasionally an incident kind of gets under their armor or affects them. Whereas if you happen to work in, say, surgical outpatients, or in a primary care sort of health clinic, you may not come across trauma very much at all. So it does vary an awful lot. And actually one of the things we're doing at the moment on the back of COVID is our team at King's College London have got a study called NHS Check. We've managed to get funded by the MRC. And this is looking across the NHS to try and actually find out what the real rates are, both now and also for going forward. But we would be suspicious that the rates of PTSD in healthcare professionals is going to be higher than it would be in the general population because of exposure.
So you think it would be higher?
Yeah, it would be higher because probably if you're a librarian, for instance, the chance of you coming across trauma other than in a book is pretty unlikely. So people who are routinely trauma exposed are more likely to develop PTSD.
I mean, it's interesting, going back to what you were saying, because it was an important qualification made about the numbers in terms of PTSD within the military, and how common currency now is military, and the next bit is PTSD. We sort of make the link. Do you think, because it's why do you think it's become such common currency? Because it's now used quite, I mean, maybe in some appropriate ways, but quite frequently within the general population.
Yeah, so PTSD as a diagnosis first sort of came into being in the 1980 in a textbook called the DSM-3, the Diagnostic and Statistical Manual, Volume 3. Great read if you can't sleep. A couple of pages of that just before bedtime is far more effective than sleeping tablets. So it came out of military experiences, particularly Vietnam, but also actually interestingly the outcome of sexual violence, rape and sexual assault also was, and people were seeing similar sets of symptoms in these groups of people, and there was an exploration for why was that happening. So the military has always been linked to PTSD because of its exposure to trauma, and that's not surprising. But what seems to have happened over time is that there is this automatic link in healthcare professionals' minds, and I have to say also in lawyers' minds, that if someone has been exposed to combat, then automatically any problem they might get must be PTSD, when actually that isn't borne out by the evidence. I think what's also important to say is the rates are definitely higher in the military. So it is right that military psychiatrists should be interested in PTSD, but it would be wrong to think that that's all they should be interested in.
And so in the way that you also talked about, you know, the more common anxieties, distresses, sort of low moods, etc., that you'd find personnel talking about, is there usefulness in understanding how that plays out, that you can start to reference within the NHS, the staff there, how you can start to use that data, that insight? Was there an expectation that there'd be a higher rate of PTSD?
Yeah, so I think what's really important is there are lots of different occupations at risk, you know, for PTSD and military healthcare professionals. But actually, if you've got war correspondents, if you've got train drivers, who unfortunately people end up taking their own life, but throwing themselves in front of trains time to time, diplomatic people, you know, who are constantly listening to British nationals who are distressed, child social workers. Actually, when you think about it, there's quite a lot of professions out there that are routinely exposed to really traumatic material. So I think actually when you put that all together, you can learn a lot from all those different groups, but you can't just say because it's right in the military it's going to be right for the NHS. That it doesn't just translate. But what has been important, and I think what's really important in the current context, is to really remember that just because you're experiencing distress symptoms, it does not necessarily mean you're ill. I think that's really, really important. And so what we're likely to see at the moment is a lot of people who are experiencing distress symptoms, doing, you know, what is incredibly difficult work. And actually, it's possible they might think, oh, there's something wrong with me. I've got this illness. I'm never going to get better. But we know that actually most people with good support and also with some time and a chance to distance themselves from that, actually most of those people will recover and they won't develop this long-term persistent problem, which is PTSD. However, a small percentage will. And the real difficulty here is sifting out the lot of people who are going to have this distress and it's going to get better over a few weeks or months from these people here who are going to have this persistent disorder. Because we want these people, the people who are going to be ill, to get into having treatment because they need to get treatment early. Whereas we want these people to get on with their lives and have support. And the problem with the Daily Mail, and nothing particularly against the Daily Mail or the Daily Mirror, is every time they see 100 people and 70 are distressed, they assume those 70 are going to be distressed for the rest of their life. What we really want is the 10% or the 5% here who've got the long-term problem and to get the treatment for them.
And are there specific things that smaller group can proactively do to preempt or certainly get the necessary sort of input from people? Are there useful things for people to be aware of, conscious of? Yeah,
absolutely. So often what's talked when it comes to trauma, the military, and also I think certainly at the moment with the NHS, is about this term of resilience. People like this kind of term resilience, that, you know, somehow I can give you some resilience training and make you more resilient through some mindfulness or yoga or some thinking skills package. Yes. Now, it's not that there's no place for that. But what the problem with that is it places very much the emphasis on the individual being resilient or not. And actually, if you don't manage to be resilient, maybe there's something wrong with you because you haven't been resilient. We've given you these 2 training courses and unfortunately you still developed an illness. What we know from the military, but also from other organizations that predictably place people in harm's way, and this is a slightly cheesy phrase, but I really believe it holds true, is that actually resilience often doesn't lie in individuals, it lies between individuals. So actually, what you have in the military, or what you have in the football game even, is you have a group of people who actually do well because they're mutually supportive. They look out for each other. They've got each other's backs. They have conversations and check in with each other regularly. And if someone's distressed, they get right in there and do what they can to make it better straight away. That's not treatment, that's peer support and buddying. And so that's really important because what we want to do actually to make the NHS and to make people have better mental health is, rather than trying to focus too much on individual resilience interventions, is how do we reinforce the bonds between people? And so what we have taken from other organizations, not just the military, but including the military, is how do we do that? And we know that all the evidence shows that having good camaraderie, good collegial support, and having really good level supervision, and that's not talking about the chief executive, that's talking about the team leader or the shift supervisor, that those people need to have the ability to connect with you and actually ask you a question that has meaning. So by that, I mean, the average conversation might be the shift supervisor, hey Neil, are you doing okay? Yeah, I'm fine. and that's the end of the conversation. What does fine mean? You know, fine can mean anything. You know, fine could mean, and forgive me for saying, it could mean fucked up, insecure, neurotic, and emotional. Or it might mean that actually, I'm perfectly okay, thank you very much. But the supervisor needs to have the skills and the confidence to get beyond fine. So I'm glad you're feeling fine, Neil. I have to say, I'm having a bit of a tough time. Oh, really, boss? Or what's going on? And actually, you then begin to get into a meaningful conversation about mental well-being. And actually, I might then say, well, actually, to be fair, I'm finding it a bit tough as well. So we know that having supervisors who can have what we call psychologically savvy chats is really important. And so what we've been trying to encourage the NHS to do, and indeed they have been, which is great, is to try and make sure all the people who are in positions of responsibility, the supervisors, the shop floor supervisors, feel confident to have those psychologically savvy conversations. Really good piece of research out of Australia in the Fire and Rescue Service of New South Wales. They did a randomized controlled study, which they published in Lancet Psychiatry in 2017. And what they did is they looked at fire station managers. So half of the fire station managers randomly allocated got an active listening skills training package, and the other half didn't. And what they used as their outcome measure was sickness absence 6 months before the intervention and 6 months afterwards. And what they found is for every pound invested in that training, it was in pounds because it was in Lancet Psychiatry rather than an Australian job, it saved £10 in sickness absence over the following 6 months. And when you tried to work out why was that, you know, what had actually gone on, the most important bit was that the supervisors now felt confident to have those psychologically savvy chats. They felt confident in getting beyond fine and in talking about mental health. So actually, if we can empower shop floor supervisors to actually feel confident to have those meaningful conversations, then actually from that flows an awful lot of positive things.
What would be, when you talk about confidence, what would people be fearful of? That confidence, if they grew in confidence, would begin to diminish? What exactly do they need confidence around?
So we've just been doing a bit of work, doing a pilot study, looking at doing this active listening skills training in the NHS. And I can tell you that before people have the training, less than a quarter of supervisors would say they felt confident in recognizing that a colleague might have a mental health problem. So the first thing is they don't know what to look for. They don't feel confident in knowing what to look for. The second thing, they don't feel confident in opening a conversation, in speaking to a colleague about mental health things. How do you start? What do you say? It's all a bit funny. We don't like talking about mental health. Thanks very much. And then also they need to know, then once they have spotted someone who might need help, what do I do to support them? Do I just say, oh, go and see your doctor or go and see a psychiatrist? And actually that's not what they should be saying. They should be saying, how do we support you? So we know before the training course that actually, you know, low percentages of people felt confident. A month after the training course, straight away, but a month later when we followed up, you know, those 25% have gone up to sort of 80%. That actually people felt that actually now they knew what to look for. Now they knew a few opening levers to have those sort of conversations about. And actually they also knew a few things they could do to support people. And if you're a healthcare professional and actually your source of distress is you are worried about not working the ventilator properly, or about not giving the right medication because you can't hear because of your PPE, you don't need a psychiatrist. You need someone to mentor and supervise you so you can do your job better. And if you can do your job better, then your distress goes down. And that's something, of course, that supervisors can do a lot about. And actually, we as mental health professionals can't do very much about. So that's the crux of what an active listening skills package does. It begins to allow people to have conversations where you can end up solving the problems. And don't get me wrong, sometimes a supervisor will find someone who actually does need a mental health professional. Someone who says, do you know, one of the questions we would use is, you know, how's tomorrow looking for you? And if someone said, I can't see tomorrow, you know, I don't even know, you know, then you're beginning to get into a conversation where actually we need to get that person to a healthcare professional.
I mean, you reminded me of just the importance, and that's part of what these webinars and the conversation with you about is normalizing quite a chunk of what people are going through. And part of normalizing it is being able to talk about it amongst peers, amongst colleagues. It doesn't.
Absolutely important. And one of the topic that's really has come up a lot, which I think is really important, and I would say that because we're doing research work on it as well, is about this topic of what's called moral injury. And moral injury describes situations that you will find yourself in that strongly clash with your moral or ethical code. So for instance, do you go and help a patient who's fallen on the floor and may be having an MI when you haven't got PPE on, and then risk getting infected or taking the infection home? Or do you put your PPE on, and then if you get there and the patient has died and you could have gone earlier, what was the right thing to do? Well, there isn't a right answer there. There's no simple solution. You know, what happens if you're living with a loved one who might be more vulnerable, even if they're not shielding, and you want to go to work. You know, what's the right thing to do? Do you move out of the house? Do you? And there often are no easy answers in these situations. And what happens with moral injury is it begins not just to be a bit upsetting, but it begins to persistently play on your mind. You know, what if only, and those sorts of questions. And that can make you have a lot of anger, a lot of guilt, a lot of shame, and therefore you start to become emotionally vulnerable. And then something happens at work, such as someone dies or an accident happens, and then you go on to develop a mental health problem because this moral injury had made you really vulnerable in the first place. And the reason that's important in terms of the discussion about talking to others is, if I'm your psychiatrist, I can't tell you that, you know, don't worry about that, that's okay. But actually your buddies, your colleagues, the people who have been there, who said, we've been this together, you know, we've had those same experiences, no one has all the answers. That is really useful. And that, we call that developing a meaningful narrative, developing a story about your situation and what happened that doesn't end up with you as the victim or you as the perpetrator. It ends up with, this was really tough. No one had the right answers. And, you know, we did our best. And actually we did do a lot of good, although everything didn't always work out. And that's best done with colleagues, particularly with leaders who can also, you know, say, actually, I didn't have the right answers all the time either.
And so the organisational element of that, how does
the
that?
Organisational element of that is we call that, you know, reflective practice. And so there needs to be opportunities as the battle rhythm goes on, that people get a chance to reflect and to try and think about what's happened. Now, this is probably not the best thing to be doing when you're in the middle of a busy shift and you're just too busy getting on with things. But as you begin to dwell on what you've been through, thinking about the enormity of all that you've done, that's when the potential for these moral injuries sets in, because you begin to develop a story, a narrative that has you as the victim or has you as the perpetrator or someone letting you down. And so what we are trying to do, and what NHS England, to be fair to them, have done is to make these reflective practice groups available. So there's something called the Point of Care Foundation in the UK, and they do something called Schwartz rounds, which is one way. It's not the only way. It's one way of doing reflective practice, and they're making them available online so that anyone in the NHS can access these Point of Care Foundation reflective practice groups. But I really think it is something that a reasonable supervisor could do, you know, sitting down with staff for half an hour session, you know, once every 2 weeks or whatever fits in the rhythm, to say, right, let's just talk about what's gone on. And actually, let me start by saying, I've made some pretty terrible mistakes over the last couple of weeks, in my view. And everybody opens up enough so that even if you don't want to open up completely, you've heard that actually we're all in this boat together and actually no one has the answers. And we think that that's likely to be useful as a protection against moral injury, and will help people, you know, be more unlikely to develop mental health problems.
One of the things I was really interested to read about and find out a bit more about was the 6-7 weeks at the Nightingale that you were very heavily involved in. Just say a little bit more about what was happening there.
Yeah, so the Nightingale Hospital in London set up sort of late March, and the Nightingale concept is a fascinating concept, although thankfully, you know, from the nation, we didn't need to use the Nightingales very much at all. But what they did was to bring people together from all walks of the NHS, and it wasn't a dedicated team. It was a group of people who got together to form a team. And to be fair, many of them, you know, I remember speaking to, you know, didn't come from a critical care background. The Nightingales were going to be full of, you know, at one point, 2,500 intubated patients, you know, which would have been a real feat, to say the least. But bringing them together, giving them some training, and then putting the specialists, the critical care nurses and the anaesthetists and intensivists available. But actually most of the bedside stuff was going to be done by people who were, you know, for instance, a paediatric audiologist, you know, who, with the best will in the world, who's very good for volunteering, but doesn't know a lot about intensive care, you know, or someone who's a dentist might be another. And so what the Nightingale concept was taking a group of people, forming them into a team, giving them really challenging roles, and then seeing how do we support their mental health, because we know that group would have been vulnerable, really important group, and I'm glad they did it, to develop mental health problems. So what we did is we developed a strategy based upon all the things we've talked about here and some of the other strategies as well. And we tried to make sure that everybody who came through, for instance, that everybody was really frankly prepared. So we didn't say, oh, it'll all be okay. We said, this is going to be tough. You know, despite your best efforts, people are going to die. And The good news is that we're in it together, and actually we're going to save a lot of lives too. So this is important work, but we're not going to lie to you and tell you that this is all okay. We're also going to ask you about whether you're really in the right place to do this. You know, if you've got stuff going on at home that's going to make this difficult, have you been involved in trauma before? Have you been, are you living with someone who was shielding at the time? You know, is this the right thing for you? And we didn't do screening because we know that psychological health screening doesn't work. The idea of giving people a questionnaire or sitting down with me or a colleague beforehand, checking whether they're psychologically vulnerable, people don't tell the truth and it doesn't work. But we asked people to reflect themselves about whether they were ready to do that work. And then we also gave them a skills training package that one of my colleagues did, which we called psychological PPE, which is the sort of some skills to try and help you personally stay safe if you were having a tough time. And that was based heavily on what's called a wellness recovery action plan, which is basically making a plan about what you will do when you're distressed. So things that keep you well, you know, the music you like, you know, the walk you go on, the people you speak to, the one glass of wine that you drink that you really like. So when you're feeling distressed, rather than thinking, what do I do? You turn to your wellness recovery action plan that you've already made. And on there is a list of some things to try to keep you well because they've worked before. So that was preparing people properly. So we set that up in place when people came in, and then we wanted to sustain people. And that basically meant training up supervisors to have these psychologically savvy chats, putting in place what we called welfare walkers, who are peer supporters, you know, who are available to chat, and they were around whenever you needed them. And we also developed what we use in the military, and we call frontline psychiatry or forward psychiatry. And that's basically trying to keep people as functional as they can. So if someone was distressed, rather than say, oh, you're a patient, let's give you some treatment and get you well, our first stance was, what can we do to keep you working? And the principles that military psychiatry or forward psychiatry is based on are called the PIES principles. And these have been shown to work time and time again. A good paper published in the American Journal of Psychiatry in 2005 by Zahava Solomon's group basically showed that the more these PIES principles applied at the time of the Lebanon War in 1982, the better the Israeli soldiers were 20 years later on. If they had, so, you know, PIES, 20-year studies are pretty rare. So the PIES principles are this. So P stands for proximity. And what proximity means is that if someone develops a problem, you don't just say, go home. What you say is, what can we do to keep you in the workplace? How can we reduce your pressure and increase your support to keep you there? So for instance, in the Nightingale, the intensive care wards were in this huge, you know, auditorium. And going in there was pretty oppressive at the best of times. But before you got there, you had to go through a don and doffing station to put your PPE on and take your PPE off. And that was mundane, you know, it was important work, but it was mundane. So if someone was on the intensive care floor and actually it was really, really distressed, we could move them to the don or doffing station where they were less distressed, they were helping out colleagues, they were doing something useful, and that allowed them a bit of time to stay proximal rather than send them home and they would worry that everyone would think that they were a waste of space and that they couldn't do the job. I stands for immediacy. So if people have got problems, we want them to be spotted earlier on so we can nip it in the bud. So one thing we were trying to do, just as it kind of close, is to formalize buddying up before people go on to shift. So on a shift, as well as doing your job, you, John, and you, Sarah, your job is to look out for each other. I want you to check in with each other regularly. If there's a problem, find out what it is. If you can't help them, go to the supervisor. Don't just let them become distressed and morose. And so you buddy up. At the end of a shift, we want to make sure the supervisor or the buddies check in. So don't just go home, you know, how are you doing? What was good? What was bad? What are you going to do next? So we want people to actively check on people, immediacy. E stands for expectancy. And expectancy says that when someone's having a tough time, a bit like we discussed about, you don't just say you're a patient. You try and normalize it. This is a normal reaction to what's a challenging event. You're going to be okay. And if you're not okay, we're going to make sure you get to the right help. And S stands for simplicity. And that basically means when people are having a tough time, they don't need 12 years of psychotherapy. What they need is some practical solutions, often a good night's sleep, you know, a good meal, a chance to speak to someone who's speaking to them nicely. And those simple things often make a big difference. And as I say, the evidence about those PIES principles is pretty strong. Now, if that wasn't able to hold someone, you know, if we did that and actually, to be fair, the next day they're still falling apart, we then need to get them to get onto a care program and get assessment. But mostly those PIES principles were what we used, and we didn't see a huge number of patients, but we didn't send any of them to get professional care. We managed to keep them in the workplace.
And that was then, so then it was utilised at the Nightingale for...
Yes, for the weeks I know the 2, 3 or 4 weeks, I forget how long it was actually operational. Yeah. But we also, because those principles made it into a plan, what we also did was distribute that plan to the other Nightingales around the country, and so we shared that. So they were using the same plan, and then that we wrote a couple of papers. So that got published in the BMJ Leader, in the British Journal of Psychiatry. And our aim, my aim, was always to try and say, here's what the evidence shows. How do we get that out into the scientific press so that we can actually share that with people who might make use of it?
And are you beginning to collate that data from the other Nightingales? Are you beginning to get?
So there wasn't data, because there's not a lot of data, because none of the Nightingales were really used very much. But what we are collating data, the Nightingales are in our study, is this study at King's called NHS Check. Is we've got over 10,000 people in the sample so far. And what we're doing there is we're looking at that data to try and work out not just what the impact has been on staff, but also what of the support mechanisms worked. Because what we really need to know is for wave 2, and hopefully not wave 3, but whatever comes next, and even life as normal in the NHS, what are the support mechanisms that really work? Because we've got lots of good ideas, but NHS Check, the aim of that study, which is funded now for a year anyway, is to do a longitudinal check on people's health to try and see what works and what doesn't.
Do you think there's certain unique aspects to this particular period, this COVID, that have surprised you, or that have surprised you in ways you might have assumed things might have played out or evolved differently?
Well, I guess one thing I would say that isn't surprising but is pleasing and isn't much reported is about the kind of alternative to PTSD in many senses, which is this concept called post-traumatic growth. So actually, when I wasn't a Nightingale, and in my moves round and discussions, I'm part of the NHS, or was part of the NHS England wellbeing team, is actually, yes, we hear lots of stories of people who are distressed and who've had a tough time, some of who need support and a few who need professional care, for sure. But we also hear lots of stories of people who actually have been through adversity, and actually they come out the other end saying, actually, I did really well. I didn't think I would be able to manage that. And actually, I've been through all this, and I've been with some fabulous colleagues, and we've been more supportive over the last 6 months than we've ever been before. And you know what? My trust actually gave me free tea and coffee, and I even have free parking for a while. And it's easy to say, well, that's not enough. But many people have come out of that and have gone through this concept of post-traumatic growth. So I think that's one of the things that, whilst it's not surprising for me, I figured that it's not really very much reported. That our media seems to be very heavy on reporting all the bad things that happen. And I guess the other thing that has been of interest is the impact of these moral injuries on staff, rather than just thinking it might be an issue. I think that has come to fruition, and we hear pretty regularly now in our research, but also elsewhere, of people who are really struggling with wanting to do the right thing, when actually, sadly, because of either resources or staffing levels or competence and skills, it's not been possible. And so I think actually, although everyone the newspapers try and tell us that everything's going to fall apart and we're going to go to hell in a handcart, I think there definitely are going to be problems out there for the NHS. But actually, with the right support, some of the teams that I've interacted with have done amazing things. And they, I remember seeing a report from about one NHS chief executive, I forget which trust it was, I should say, because they were really good, who wrote to the children of the people who work in the trust and said, your mummy and daddy have made a huge difference to people's lives. Thank you so much for letting them come to work. Now, that probably wasn't a very expensive intervention. I don't know how they found the addresses, but what a lovely, supportive, we're in it together activity. And there's been some great examples of that, alongside obviously things that haven't been quite so good.
Do you think it has its own difficulties to be able to talk about it in a positive way? I mean, who coined, or where did that phrase come from, or way of seeing?
Post-traumatic growth, as many of these things do, came from the States. I can't quite remember who coined it, but it's been around for a while. We have a post-traumatic growth inventory and a short form of that, which we're using in our research, so it's measurable as a concept. And it's about a growth in attitudes and resilience and belief, self-belief, and organizational belief as a result of going through difficult experiences. The early research into it wasn't sure whether you needed to become unwell, so develop PTSD and then get better and then grow, or whether you could just go through adversity and grow without the need to become ill. And I think the evidence at the moment seems to suggest you absolutely can grow without the need to become ill in the first place. I agree with you. I think when all the stories are about these sad cases, which there are, it's difficult perhaps to put your hand up and say, actually, I'm finding it rather fun, and I'd like to do more of it. But certainly, if you walk the shop floors, you will hear some of those stories. But no one wants to dismiss the fact that there are going to be substantial numbers of people who don't have that experience.
I mean, now with this second period, do you have your own view of where to continue to pay attention in terms of emotional and mental well-being?
Yeah, so I do a lot of work, I have done with the military. I do veterans lead things. I won't bore you all veterans charities. Now, one of the things that's in the world of the military and the veterans is something called the military covenant. And what the military covenant says is that no veteran should be at any disadvantage as a result of having served in the military. So it's not trying to say they should get the best care, but certainly if there's more PTSD, then they shouldn't just have to wait in the same queue as anybody else, because if that's an occupational hazard, then the nation recognises that and they will get a supportive and special service. And indeed, there are veterans mental health services within the NHS set up to provide specialist mental health care just to veterans if their mental health conditions are related to service. And the phrase there, the key phrase once again, is no disadvantage. Now, veterans have put their lives on the line, and many of them for the country. But actually, if you translate that to what's happening now, well, actually, there's lots of people in the NHS who are putting their lives on the line, and certainly their well-being on the line as well. And I feel that what is needed is something akin to the military covenant for NHS workers, particularly ones who have gone above and beyond and been asked to and have absolutely volunteered to do that. And I think it's quite hard to distinguish who has and who hasn't, because whether you're a hospital porter, administrator, HR professional, your input into this is really important. I'm always minded of that phrase, the situation where someone goes into NASA and sees a person sweeping the floor and it says, what are you doing here? And he says, I'm helping put someone on the moon. And I think that is just as applicable to a whole wide range of NHS staff. Mm. So what does that mean in some sense? Well, what it means is that at this stage, as we begin to hopefully recover at some point, we need not just to say to NHS staff, well, thanks very much, get on the back of now the slightly longer waiting list and, we'll do what we can. I feel that there is a need to recognise what's gone on and not to disadvantage other people, but to absolutely make sure that just because they've helped everybody else and done their all, that they're not disadvantaged. I think that's really important. And I think the other thing, just at this moment right now, is if you look at intensive care staff, and staff who will be asked to work in intensive care, even if they're not intensive carers, and then there'll be volunteers to do that, is we need that team on the field. We need that team on the field in a winning formation. We need them to be as occupationally adept and agile as they can be at this moment, because they're going to have a challenging task. So what that means is, I don't think we should provide them with extra mental health care because we need to be nice to them. I think we need to make sure their mental health is really good at the moment, because we know there are very strong links between having poor mental health and poor performance. So if you want staff to perform really well over a time point and over in challenging circumstances, you need to make sure. So I think that if we have a need for mental health support at the moment, it needs to go on the staff who are going to be saving lives. And that's not trying to say that other people aren't worthy. It's just for the whole nation, we need them to be as functional as we can. So I think right now, that is very much what is needed. But in the longer term, I strongly believe that the military covenant principles should be applied also to NHS staff.
And the point at which that would have transferred into medical staff would be a point at which each practitioner would be able to see, they'd have their own attention given for their mental emotional well-being.
Yeah, well, absolutely. So I mean, the mental emotional well-being obviously starts with, if you believe in these strategic things like the NHS People Plan, where, for instance, the new plan that's out recently, the People Plan, says that every NHS staff member will be able to work flexibly if they want to, rather than being told, sorry, you can't because that's not allowed. And anyone will be is entitled to access, well-being support rather than say go to your own GP. So I think the offer to NHS staff should be, we will do what we can to support you, which as an occupation, as an occupational sort of group, makes sense. No one wins by having, a nurse or indeed a porter or an administrator off for 8 months. They sit on a waiting list and then someone has to fill their job. What we want is to get them back into the game as soon as we can, if we can do that. So I think that's where the offer starts. The offer starts, come and work for the NHS, because actually we're really going to look after you. Actually, it's not just for you, it's also for us, because we really want you at work and doing a really good job. And I think that's a strange mindset, because you then start to think, well, you know, if we're going to give 1.5 million staff, which is what it is, you know, sort of extra support, where's that coming from? You know, who's going to pay for it? My view as an occupational psychiatrist is actually it will pay for itself, because if you look at staff sickness levels, you look at retention, the cost of retaining and training people, if you can make a difference to that, then actually that will pay for the service. I used to think when I was in the military that if I saved one helicopter pilot a year, I could sit back and do nothing, because a helicopter pilot will, you know, cost £1 million to train. So I've done my job. I've earned my salary. I didn't earn anything like £1 million, you know, but I've earned my salary time and time again. So if we can save NHS staff and stop them becoming ill or stop them becoming sick, then that's going to absolutely save far more than I think the interventions are going to cost.
That's a brilliant summary of the work you're doing up to this point. I mean, it's has been realistic and acknowledging, sort of seeing the challenges, but remaining very optimistic and positive about humans' ability to engage with these things in ways that do become positive in their lives. I particularly like you're sort of inviting a positive tension between members of staff, a sense of everybody being aware of everybody else, from a place of care, support, kindness, and just that alone.
Yeah, and indeed compassion. I mean, I think this idea that actually, rather than, oh, why didn't they do that? And, you know, the first thought is someone's not doing their job, is, gosh, you know, what's up with them? How can we help? Because actually, if we're not all in it together, if it's really those over there aren't doing their job and only me and my colleagues are, then we're never going to get anywhere. And the military is a funny group of people. You know, lots of people join the military because they come from, you know, challenging backgrounds, or they want to get away from something, or they're after this kind of, you know, exciting lifestyle. But actually, you take a group of people and you put them together, and actually they do an amazing job because of the team, not necessarily because of any individual in that team. And the military, you know, take people from all walks of life, and they ask them to do really difficult tasks. And on the whole, they do them really well. They do them in spades. And I think the NHS, you know, the aim of the NHS is to save lives and help people. I mean, the aim is completely laudable, but there has been, I think, over the, you know, for as many years as I can remember, this whole feeling that they're oppressed and we can't do it, and they're not doing their bit and we're not doing our bit. So I really believe that the future has to be, not just because I'm optimistic, but it has to be for the good of the staff, but also for the good of the organisation performing well, that actually we have to believe that, you know, we're all in it together. I think that's really important.
Thank you. I think what we can do is start to bring in, I'm sure there's quite a few questions that some of the people watching the webinar have got. Anthony, what's some of the questions you've got?
You're on mute.
You're on mute, Anthony.
Yeah, unmute yourself. There you go.
Thank you. Sorry, I was locked on mute. So we've got quite a lot of different questions. What should we start with? So what parallels are drawn between military and medicine, and does the military provide mental health resources that the NHS doesn't?
So the military has a dedicated mental health service, the Defence Mental Health Service, and that comprises of psychiatrists, you know, in all three services, mental health nurses, and also psychologists, most of which are civilians who work with the military, and also some social workers and occasionally occupational therapists. So if you are in the military and you are psychologically not well, you'll go to your GP, your unit medical officer in most cases, and they have a very low threshold of referring someone on to mental health support. And so often you will get, say, for instance, I worked on a nuclear submarine for 7 months. So if you've got a junior sailor and the submarine's about to go away for 2 months and stay under the water to do whatever it's going to do, and the junior sailor's just split up from their girlfriend and they're really distressed and upset, do you really want that person on that submarine? Because once the submarine hatch is shut, it's down underwater for 2 months. So the military mental health job is to work out, is someone occupationally fit, and what can we do to keep them at work? And so they have that service. It's relatively easy to access it. It's occupationally focused, but it does also provide treatment. You know, if that particular junior sailor, for instance, actually wasn't just a bit upset, they actually had an adjustment disorder or depression, and they needed, you know, cognitive behavioral therapy, or they needed some medication or occupational adjustments, we would, when I was in, would sort that out as well. And one of the absolute pleasures of working in the military is if you had, when I was based, for instance, down in Portsmouth, and so Portsmouth has lots of Navy ships, slightly less now than it used to. And if you happen to see 6 people come in from HMS Northumberland, which is one of our frigates, and they all come in from the Marine Engineering Department, and they're all a bit upset and they don't like it and the work's difficult. They're all from the same department. Now, isn't that strange? And the Chief Petty Officer Smith is the Marine Engineering artificer who's in charge of that. So actually, the problem may not be these 6 people. It may be Chief Smith. So actually, rather than necessarily trying to, you know, talk to them about perceptions of bullying and harassment or difficult work, maybe what I needed to go down is to have a chat with Petty Officer or Chief Smith. And that is the pleasure, because you can go into an organization and actually try and find out what the root cause is. And often that can make a huge difference. And, you know, so we were able to do that. And it might not be that the chief's done anything wrong. It might be that, you know, he didn't feel confident to talk about mental health. It might have been that he had problems himself. You know, him and his wife were splitting up, which is why his behavior changed. So that's one of the pleasures of military life, is that you know the environment because you've served yourself, but also you know where to go to. And I think one of the translation there to the NHS is you don't want to just rely on NHS mental health services that are very distant from your workplace. You need some, not a lot, but some mental health professionals who are able to understand, you know, what it is to work in Lincolnshire General Hospital in the dermatology department, or at least to know how to go in there and have a chat to people if lots of people come from there. So being able to go in and manipulate's the wrong word, but, you know, attune and change the dynamics in which people work can make a huge difference to people's mental health. And I think what that says for the NHS is we need to have mental health professionals whose role it is to help the organisation do better and to try and get people to stay at work where that's possible, rather than just say, oh, you're a patient now, we'll give you a fit note, we'll sign you off for 3 months while you have cognitive behavioural therapy. And you know what, when you go back, the CBT that's made you feel better hasn't going to change your workplace dynamics, which is why you got unwell in the first place. So let's try and do something about that.
Mm. Does that mean that, where do you see CBT sitting in this sort of work then?
So there's absolutely a role for, you know, cognitive behavioural therapy and a range of other psychotherapies, behavioural activation, and, you know, whatever else you might want to, you might need to use. But the point is that if the cause of someone's difficulty is a workplace difficulty, so it's not feeling confident on the job, it's relationships with supervisors, then no amount of CBT is going to necessarily change that. So actually what's really needed, maybe alongside some CBT to improve your confidence, is also changing something in the workplace. And that might well be that, with the patient's permission, whilst you're doing the CBT, that actually part of the sessions are to bring the supervisor in, or at least to communicate with the supervisor. Obviously, you've got to respect confidentiality, and people are worried. But if you ignore the workplace stressors when you're trying to do interventions, then inevitably you're not going to necessarily get people back to work. Or if you do get them back to work, the problems are likely to reoccur. No, if it, on the other hand, has got a boss who's completely reasonable, but the person's self-confidence is really low, which is why they're misinterpreting, absolutely, the CBT may absolutely help them to change their view of the workplace. But in my experience of working occupationally, there often is a dynamic between how someone becomes unwell and their workplace colleagues and their supervisors, which often needs some addressing.
Is there in development already or in place a strategy for how to, because essentially it's very clear the sort of position, the way you want to approach this, the implementation of it, the taking it on board.
So what there is at the moment in terms of NHS that I'm aware of from NHS England and Improvement, NHS People, is there is an ongoing plan to provide what are called local resilience hubs. And these are going to be in all the trusts. I'm not quite sure how that's going to be distributed to primary care, but it's important that it does get distributed to primary care and the rest of the NHS as well. And the idea is to have a small group of mental health professionals whose job it is to go into workplaces, to do some training, to help supervisors feel more confident, to see people quickly, you know, if they've got a problem, not to give them treatment necessarily, but to see what they can do to help someone stay at work and to try and get them back to the workplace, doing that sort of liaison that I mentioned, you know, going into workplaces and speaking to managers and assisting them where they can. So there is a plan that's going to happen. I think that's already underway, but it's kind of a slightly different model to the classic occupational health model. And occupational health is really important, I would say, but occupational health normally doesn't have specific psychological health professionals in it. You know, it has some very competent occupational health nurses and physicians. So that will work alongside occupational health, but will take a psychological focus and look at, you know, changing what it can in the workplace. So that is underway. I'm not an NHS England improvement person, I can't tell you how far along that's gone, but that is in the plan.
Yeah, thank you.
That was a really interesting answer. I think as well, as the models of employment have changed, so lots of trainees are now employed not by trust they work in. Occupational health has become a bit more remote for a lot of trainees, trainee doctors anyway, which is quite difficult, I think. It's much easier when it's within the organisation for organisational factors to be taken into account, I guess.
I would agree with you. So I'll declare a conflict of interest. I'm a trustee on the Society of Occupational Medicine. I think occupational medicine is a much non-understood specialty at times. I did my diploma in occupational medicine some years ago because what I like occupations and mental health. And so I think occupational physicians and occupational health departments actually have a huge role to play where they can. I agree with you. There does sometimes seem to be difficulty in people accessing their help and support, you know, with the, no, we only cover that particular group over there, we don't cover this group. And I agree that's not helpful, because if you're working in an environment, you absolutely have to have the occupational health cover, you know, particularly with COVID at the moment in terms of physical health risks. You know, it is quite rightly the occupational health physician's role to take account of that. And I think that unfortunately, my experience to date, you know, is that many mental health professionals don't always get the occupational element. I think that's not surprising. You know, if you're working in a PQ, for instance, you know, then actually day to day, you're not seeing a lot of people who are going back to work next week, and so you're not thinking about health. But in fact, for most people at work, by the time they come and get to see a mental health professional, they're going to be really severely unwell. So that's why we need to push the psychological understanding a little bit further forward, so they can get it before they become so seriously unwell that they can't be at work.
That actually brings us quite nicely onto the next question, which is, who's responsible for doctors' mental health?
Gosh, so I mean, I think the responsibility lies both in the individual, because they're responsible to a large degree themselves, you know, because the organisation only knows what it knows. But also, if the difficulties occur as a result of things that happen at work, the occupational health and safety laws and the health and safety executive would absolutely say that the mental health at work is an important topic, and it's something that employers have to know something about. So you might not be aware, a couple of years ago, a good report came out called the Stevenson Farmer Report, called Thriving at Work. It's about occupations generally, not just about the NHS, but the NHS certainly applies to it. And what it made very clear was that basically, particularly big organisations, and I think the NHS would count as that, they absolutely have to have a plan that doesn't just take account of, you know, slips, trips and falls, but it has to take account of the occupational risk, of the psychological occupational risk of the work that people do. So you know, we all here know that staff who are going to work in paediatric social work, you know, in paediatric environments to see children, unfortunately, who have suffered child sexual abuse, it's not going to be surprising to anybody that that's going to be psychologically tough work to deal with. So organisations can't say, "Oh, I didn't realise Anthony, you know, might be affected by that," because it's barn door obvious that Anthony might be. So the question is, what have you put into place to make sure that you've minimised the risks where possible? And that might be supervised training, it might be peer support, it might be reflective practice groups, you know. And so I think actually the responsibility is on the organisation. But at the same time, if Anthony hasn't told us that actually he's going home and drinking a bottle of wine every night, or 2 bottles, and actually he's coming to work smiling, how is the organisation meant to know? They can't put a secret service spy at Anthony's house to check on him. So there is a bit of a shared responsibility. And what I often hear is, "Oh, I couldn't tell anybody, because if I did, I'd lose my job and people would think I'm stupid." And I think that what has happened over time is that culture has positively changed in that respect. It has not gone away. If we look at the Adult Psychiatric Morbidity Study. Try saying that one after a glass of wine, which is a good study done every 7 years in England. So in 2007, this is an interview-based study of mental health across England. We know that about 1 in 4 people with mental health problems were seeking help at the time. 2014, so 7 years later, that 1 in 4 had gone up to 1 in 3. So the direction of travel is right, but there's still a long way to go. What we showed in our military studies, and we measured stigma over many years, is that stigma was gradually going down over time. But it still was that most people with difficulties weren't seeking help. And I think what we need to do is to keep plugging at that, to get people to really believe that actually you're more likely to keep your career, actually, if you go and get help early on, than you are in just sticking it out, and by which time you lose your career, but you lost your family and your self-esteem as well. But of course, organisations need to make it okay to come and get help at the same time.
Yeah, I mean, I think, again, one of the really important key bits of these webinars is just normalising the emotional turmoil people go through, not diminishing the seriousness of it, but that it's okay to talk about it. I mean, literally in real time, the way that you're talking, Neil, to me is a way of informing people and normalising, saying these are things that we're all going to face in different ways at different times in their lives. And just the key importance, when you said earlier about the responsibility of the individual, just the positive, proactive act of being able to tell people just seems so clear in the way that you're talking.
Absolutely. And obviously the other most important thing is that you follow me on Twitter, because that's definitely going to protect your mental health. At Prof. N. Greenberg, definitely worth doing. You'll definitely feel better afterwards. And if you don't, I will.
So I'll move on to the next question, which is, what is your practical advice or steps for doctors to take themselves who are struggling to deal with what they've had to face during the peak of COVID?
Yeah, it's a really good question, and I think that many doctors will be in those sort of situations. I guess because of what I do, I get random emails from people, or people's mother or people's girlfriend saying, you know, my loved one is falling apart. What should they do? I think probably the most important thing is to first of all take stock of what other people around you who know you well are telling you. So actually, if you're thinking, actually, although I'm not sleeping well and I'm a bit more grumpy, actually I'm okay. But actually your partner, your children, your work colleagues, if everyone around you is telling you not okay, there's probably a reason. So first of all, it's recognizing, you know, is this a problem I can cope with myself? Because some things you can, obviously. But actually, if it's getting to the point that everyone around you, the people that matter anyway, know that something's wrong, then I think you need to take a next step. What that next step might be to alter your job. You know, you might decide you're not going to do those extra overtime shifts for a while. You're going to take that leave that you have been building up and you haven't done anything with it. You're going to stop doing the 72 other things you're doing because there's no time for you to do anything. But if you try doing stuff yourself, you know, test and adjust, and it hasn't worked, then I think you need to reach out to somebody. And that person you might reach out could be your GP if you get on with them, because many GPs are great. It could be using the national support line, and so you can speak to someone in confidence. They won't even know who you are, so you know they can't possibly tell anybody. There's a text back service as well, or actually locally, there may well be sort of what I often call an aunt or an uncle. You know, someone in the department, someone who actually, they might not be your boss, but everyone knows they're a good egg. And actually, most of those people, if you say, "Have you got 5 minutes?" You know, they'll find you 5 minutes, and actually, sometimes they can really help solve. But don't keep struggling on by yourself when that hasn't worked and when you've tried to do things but that hasn't made any difference. Because the evidence is, if you look at post-traumatic stress disorder, getting back to that, that actually both in a civilian setting and also in the past in military settings, not so bad anymore, sometimes people waited 7 years, you know, before getting help. And by that time, you know, their life trajectory had changed negatively, you know, they've lost relationships. And actually, although you can treat PTSD after 7 or 10 or 15 years, getting rid of the symptoms isn't the main problem by that point. It's trying to re-establish a normal and healthy pattern of life. You know, you're drinking, you've lost your friends, you're living by yourself, you know, you perhaps lost your job. You know, it's the symptoms of PTSD. Yes, we can get them better, but rebuilding a life takes time. Whereas seeking help whilst you still got all those things, okay, I agree it's difficult, but actually that is the way to go if management isn't sorting it yourself.
Mm-hmm.
I really like the continued emphasis of community. Community seems to go right through the core of a lot of what you're talking about, really. is a sort of communication, connection with others that are just peers and colleagues, or just people that, you know, by reputation will listen or will be sympathetic or just be available. Just the simple truths of all of that, I think, is very striking in how you've been talking.
So I served, as I said, I served in the Navy with the Marines. I did all my silly Marine things and went and got my Green Beret and all that kind of climbing up ropes and there's silly stuff. But one of the things the Marines do really well is they really do team well. Yeah, that they absolutely go to funny places and they have got each other's back and that's what they're good at. And about 20 years ago now, or perhaps even a bit more than that, there was a recognition in the Marines, you know, that unsurprisingly some people were having mental health problems. You know, that's not a surprise to anybody. But the chap in charge at the time, who was the brigade commander, rather than say, oh, well, they've got to crack on, for whatever reason, he said, right, we need to do something about this. We need to go and make it better. And so he tasked a completely non-mental health professional, he was a policeman, actually, a military policeman, like, go and find out what we need to do to make this better. And at the time, something called psychological debriefing that you've probably heard about was sort of in vogue. This is the idea of flying in counsellors, you know, after traumatic events to make them better. We now know that doesn't work, and in fact makes them worse. You know, the NICE guidelines specifically recommend against the use of psychological debriefing after trauma because it doesn't work and makes people worse. But what happened, they started off with, they got a psychological debriefer in, and actually the Marines didn't like that, didn't really fit, don't want this kind of pink and fluffy stuff, it doesn't fit with our culture. So instead what happened is a few colleagues and I jumped on that bandwagon. We developed a peer support system called TRIM, Trauma Risk Management. And the idea of this was to train frontline Marines and chefs and, you know, infantry people how to basically have a structured conversation with a colleague who's been through a traumatic event, not to make them better, because we're not training people to be counsellors or debriefers, but to find out how they're doing. And we use a 10-item checklist, you know, with things like, did the person think they were out of control? Did they think they were going to die? Did they blame and shame, alcohol, social support? I won't bore all of them. So basically, it's a simple structured interview that takes place a few days after a traumatic event, and then about a month later. And what you're doing is you're monitoring someone to see whether they're recovering. And if they're not recovering straight away, you get them to have extra support within the unit. You look after them, you reduce their pressure for a while. And if after a month they're still not recovering, you metaphorically say, come on, mate, you put your arm around them and you take them to see the medic, you take them to see a doctor. So it's a way of active monitoring, which is what NICE say we should do. But it's based upon the fact is the best bonds between people are between people who are like you. Because with the best will in the world, as a psychiatrist, although I got all my badges and the like, when I turn up in a military unit, everyone's going, the psychiatrist is here, the psychiatrist is here, you know, oh, I'm a bit busy, doc, I'll see you later. But when Sergeant Smith turns up, who's a TRIM practitioner, who's just like them and sits down and has a cup of tea with them, and actually they can have a conversation that, to be fair, I just can't have and I don't need to have. So that this TRIM process, we've done 13 academic papers on it now. You know, it's not penicillin for trauma by any means, but it's a really widely researched and overall very supportive and effective way of managing the psychological impact of trauma by using peer support. And the crux goes back to, you know, your point, Chris, is that this is about reinforcing the bonds between people, using the community as both a supportive and an early warning mechanism, and then helping people. And for the few who don't get help that way, is making sure they get to professional care early on.
Just to clarify, because I'm sure there's some people who are quite interested, clinically, why is early intervention a negative for people? What's the thinking?
So the early intervention, the psychological debriefing intervention, is typically, you know, 3 days after an event, or maybe 4 days, or maybe even the day after an event, to have a trauma counsellor come in. So what we know is that, you know, most people after a traumatic event will recover without the need for any sort of professional intervention. The trauma debriefers or the psychological counsellors or the like will come in, and actually, understandably, they often focus on the people who are the most distressed. And what seems to happen is that in the aftermath of a trauma, as we begin to try and make sense of what's happened to us, is actually what we don't need is to be re-exposed and talk about the trauma all the time and how terrible it was and how, because actually those reactions are not pathological. They are completely non-pathological, they're normal reactions. But most trauma counsellors and debriefers, of course, they're used to seeing patients. And patients with those sorts of symptoms, actually, you know, if you're like that 2 months later, you do need some help. So what happens, you start to put a medical psychotherapeutic model onto someone who's having a very normal reaction. So you start to try and sort of tell people that that they shouldn't have that feeling, or that they need to think about it in a different way. And actually, you're interfering with a normal recovery process. If you think about it in a in a surgical sense, you know, if you've got an injury in your arm, you bang your arm, you don't need a surgeon to come in. You need to let that bruise to heal over time. So what seems to happen is, for most people, the debriefing probably doesn't make any difference because they're going to get better anyway. But the people who are the most distressed, it seems to actually increase that distress, and then inevitably they get dragged into this medical model, or there's something wrong with you, and then they go into therapy and the like. And what happens therefore is you may well end up undermining their normal recovery process. So then what happens is, later on, if there's another trauma, they think, oh, I can't survive, I need to have that, you know, that counselling again. So overall, NICE, I don't know how well you know NICE, I sat on the NICE PTSD guidance. NICE very rarely say don't do something. So for instance, there's suggestions out there that swimming with dolphins is good for PTSD. I'm not saying it's not, but we don't think we have good evidence to say that you should swim with dolphins. So NICE don't say don't swim with dolphins. NICE quite rightly just don't mention dolphins. It's not something that's in the guidelines. For NICE to say don't do debriefing suggests not just that it's unhelpful, but that it doesn't work, but that it's frankly unhelpful. And that's why NICE specifically warn against it, at least in the immediate aftermath of the trauma. The role for professionals is for the people who are, you know, a few weeks, probably a few months down the line, who are still unwell. They're the ones who need our sort of input.
Thank you.
So we've got quite a few more questions. So we've got two that are combined together. So have you got any tips for supervisors listening now to try and help empower them with this kind of conversation, particularly if they can't access formal training? And I've got one from a medical student who's asking, are there any mental wellbeing active listening packages that they might be able to access that you're aware of?
I don't know if there's still spaces. So the NHS England Improvement were making what's called REACT training. I've got a conflict of interest. My little company runs this training, but REACT training is an active listening skills package that was free to people in the NHS. You could sign up to it for free on the NHS People website. I'm not sure if there's still spaces. If there are, you could certainly go on that. The plan is to try and roll that out locally so that individual trusts can deliver that over time, which is much better and much more ethical. So in terms of individuals, I think that actually, if you were to look, for instance, on the Mind website, there's quite a lot there about supporting colleagues. The Royal College of Psychiatrists has information sheets about the same thing. And the most important thing when it comes to active listening is to do exactly that. Is not to feel that you need to necessarily do something to make people better. And giving people a damn good listening to actually can make a difference. So the package that we've used with the NHS is called REACT. And REACT is an acronym, as many of these things are. And what R stands for recognise. You know, how would you recognise that someone was affected? And again, there was plenty of information on like, for instance, the Royal College of Psychiatrists PTSD sheet. Not that people have got PTSD, but about the sorts of reactions that occur. You know, are people jumpy? Are they not their normal self? So recognise. Then you want to engage someone. So, you know, what levers can you use rather than just saying, "Are you okay?" and they say no or yes, and then you go, "Well, I don't know what to say next." So try and use a bit of your own experience, not to share necessarily what you got, but to try and make it okay that the other person might have some symptoms not being okay. And if you're a supervisor, you can probably also say, well, actually, other members of the team, not mentioning any names, have been finding this moment pretty tough. So you're trying to say, actually, it's acceptable for someone to actually reveal that they might not be 100%. A stands for actively listen, and again, you'll be able to look up active listening skills, you know, nodding, reflecting, you know, good eye contact, posture. C stands for check risk, and actually, I think this is really appropriate at the moment because there's been lots of discussion about suicide. You know, just to reassure people, whatever you might read, asking about suicide does not increase the risk of it happening. So actually, although you don't say, "Hi, my name's Neil, by the way, you think about taking your own life," that would be silly. You know, if someone's talking about things being really bad and seeing no point, if you say, "Can I ask, have you ever thought there's no point going on?" that is not going to give them the idea to do it. So you should not be afraid of asking questions about people's behaviors, because actually it may be a huge relief for them to say, "Actually, I have." And then you're in a great position, not because they're unwell, but because you can do something about it. You can help them. And then T stands for talk about a specific plan. So often as a supervisor or colleague, you don't need to be giving them psychotherapy. You need to be helping them to do things at work which might be difficult for them. You know, check a skill, supervising them. You know, if there's a relationship difficulty as a supervisor, you can, you know, subtly get involved, maybe alter people's duties or flexible working. So actually there's an awful lot you can do just by giving people a damn good listening to. And the most important thing is, unlike I'm doing now, is to shut up. And once they start talking, just let them go. Don't interfere, and don't try and problem solve before they've finished saying what they're going to say.
Thank you. We've got quite a lot of questions, so I'm going to try and crack on with them. So what are your thoughts on MAPS research on MDMA-assisted psychotherapy for treatment-resistant PTSD? This was in the Royal College Congress, actually, a few weeks ago, wasn't it?
Yeah, I think there should be a lot more MDMA, I think. No, so the key thing is that, just as the question says, this is not MDMA to treat PTSD. This is MDMA-assisted psychotherapy to treat PTSD. So that's the first thing to say. So there are a few studies out, mostly, there are, I think they're all from the States, looking at this in some detail, quite a lot of them in military veterans. There is a study going on in the Netherlands, a study going on in Cardiff, led by Neil Kitchener and Jonathan Bisson and their team, looking into this use. At the moment, it's been reserved for people who have got effectively treatment-resistant PTSD. So their conventional treatments haven't worked. And what the MDMA seems to do, possibly, is in those MDMA sessions, and it's not all MDMA sessions, I think there's 2 or maybe 3 throughout the whole of the therapy, it allows people to open up in a way that they wouldn't normally feel able to. And in doing so, the theory is that helps break through those avoidance thoughts and avoidance behaviors. I think it's an interesting innovation. I think we need to understand more about how it works. For instance, one of the studies of military veterans, I forget how many were in it, but a large proportion of them were people who had taken illicit drugs whilst in the military or afterwards. Now, most military personnel don't take illicit drugs. The military does drug screening tests. So those people selecting into that trial were not a representative, proportion of the military. So I think it's definitely watch this space, but I don't think you should be rushing down to your chemist, ordering in your MDMA at this moment to start the treatment, but worth watching.
And another question we've got is there a kind of a qualitative difference between those who experience trauma and have post-traumatic growth and those who have developed PTSD? Is there any differences that we know between the 2 groups?
So there is, and actually we part of our work, this is with veterans at King's, has been to try and look about the people that sort of go down these different routes. What seems to happen for most people is that trauma doesn't have a major impact. For some people it has a bit of an impact, and it can create these sort of moral injury situations. And then what happens is that you begin to try and make some sense of it, which is what most of us do. So if we can't just put it to one side or ignore it, we try and make some sense of it. And actually what happens with the growth people is that maybe because of their state of mind, maybe because of something someone says or some other experience, is as they begin to make sense of it, they begin to link in the positives of what happened rather than the negatives. And in some ways it has to have impacted upon you in order for you to have a potential either to become unwell or growth. I don't think we yet have here are the 3 ways to make someone go down the growth line. But what I can say is in the early stages, as you begin to try and make sense of it and what happened to me and what did I do, having a colleague or supervisor or friend or family member be able to inject in information that is supportive of what you did can be really helpful. And that can't just be reassurance, oh, I'm sure you did okay, because that doesn't help. But actually it's it sounds to me as if you could have gone A, B and C, but actually having done D, of all those options, you made the best of a bad bunch. And actually having someone who can say that with the authority of understanding their situation is really important, rather than just someone saying there it's all okay, because that doesn't really help. So I don't think we know yet enough, but we do know that as people begin to make sense of it, having that ability yourself or with others to try and find a positive route through actually can make a big difference.
Thank you.
I think we've got enough time for one more question.
Oh gosh, wow, we've got the pressure now to pick which one. Probably move on to maybe one of the more military questions, because there's a lot of military questions. So perhaps this is quite a good one. So do you think there's a big difference between the camaraderie you experience in the military and the camaraderie that there is in the NHS?
I think that there definitely is a difference. So the differences come from basically the sorts of people that join, the training you get, but also the structures. So by that, I mean, in the military, you get people who join up who are looking for, you know, a different sort of adventure much of the time. You know, although some NHS staff are similar to the military, most of them, I think, probably hold different sets of values and beliefs about life, because the military clearly is there at times to take life if it has to, which is not what most NHS staff do. It's different to the people who join up. In the military also, the training is often very collective training. So people will be together on basic training, you know, for 12 weeks, and then phase 2 training maybe for more than a year. You're with the same group of people, you know, you are reinforced to connect with them, to rely on them. The NHS, of course, does training many times, but you often switch between different teams. And then when you work, you know, you may, on different shifts, you may never work with the same people, you might not work with them very much. And so that collection of being a group that is used to working with each other and knows each other's foibles and strengths, I think is more difficult within the NHS. And I think another thing that I found, which perhaps isn't surprising, but probably should be, is that in the military, there's a very strong emphasis on leadership right from the junior level. So the Lance Corporal and Corporal who haven't been in very long, they are encouraged to take charge of their colleagues in the situation. Often when you have an exercise, they'll say, right, the corporal's dead, you're now in charge, what are you going to do? Whereas I think in the NHS, it's not like that. You wait to get promoted, perhaps, or to get officially put into a supervisory position before you might take charge. And so there is an expectation from the military that they want people to take charge at an earlier stage. I think my experience of working with NHS junior leaders is actually they're fabulous people, but it's not necessarily ingrained in them that actually they are meant to be taking charge. And they're probably not also given necessarily the people management skills to go along with that. Often you get promoted because you're good at doing your job and technically you're very good. Whereas the military, to some degree, I'm not saying it's got it right, also looks about your ability to actively manage other people in selecting you for promotion to a higher rank.
Thank you.
Neil, thank you so much. I mean, my sense is there's still loads of questions, but we're going to have to come to an end. We're probably going to have to try and persuade you to come on again at some point next year sometime. But I think the thing for me that I found a very, very positive conversation, which isn't diminishing or diluting the seriousness of some of the challenges that we're facing, but the sense of possibilities and things actively beginning to change within the culture is sort of what I'm taking from it, but also inviting people to, in a very positive sense, take responsibility as well for their mental health in terms of coming forward. That it's okay, to be honest, to sort of reveal some of these things, because it just so clearly is a positive step, even if in the moment it feels so difficult to take.
Absolutely. And you know, if I end on that positive note, I would say, going back to the last question, don't only feel that it's okay or it's important for you to speak up, but actually if you see one of your colleagues or someone else who you don't think's right, don't feel hesitant in coming back. Ask them how they're doing, because if we're in it together, then actually at some time they may need to look out for you. So look out for them and ask them compassionately and honestly how they're doing, and give them a good listening to. And if they need some help to get the right help, then try to do your best to advocate for them. Because I think that the better connections that we get between our team members, the better everyone will be.
Brilliant, brilliant, brilliant way to end the web.
Okay.
Thank you so much, Neil.
Great. Bye-bye.
Thanks. Bye-bye.